Hi, I'm Tamara Thomas, content editor for Urban Health Today, and I'm speaking today with Dr. Manju Subramanian, an ophthalmologic surgeon at Boston Medical Center and the study's senior and corresponding author. She's speaking with me today about the impact of race on short-term treatment response in diabetic macular edema. Thanks for talking with me today.
Thank you for having me.
All right, so let's jump right into it. Can you walk us through the data regarding the disparities that you found in your study?
What we did was we looked at treatment response for a common condition that causes a common condition called diabetic macular edema that we see in patients with diabetes. It's the most common cause of vision loss in diabetes. And it's actually diabetic retinopathy, which is what develops in the eye as a result of prolonged diabetes and uncontrolled diabetes, is the most common cause of blindness in people ages 20 to 64. There are some really good treatment options out there for both diabetic retinopathy and specifically diabetic macular edema. And they include laser treatment and they include injections of medications in the eye. And there are 3 different medication options available to patients with diabetic macular edema. And what we did was that we took one of those medications, the most common one that's used to treat diabetic macular edema, and we looked at outcomes of this particular treatment by race. And the reason we did this is because here at Boston Medical Center, we see a large number of patients who are ethnic minorities and who are African American. And as a result, we really are able to study racial disparities and things like this quite well. Whereas in most clinical trials that are run looking at treatment options for these types of diseases tend to recruit racial and ethnic minorities sort of in line with the general population, and sometimes even less than that. But because we see so many minorities at Boston Medical Center, this was really something that we could study well. And so what we found was that for treatment of diabetic macular edema with the medication called Bevacizumab, the brand name is Avastin, we found that African Americans did less well in the short term. And I want to emphasize short term because we looked at outcomes after a single injection and looked at outcomes after 3 injections and compared them by race. These treatments are sometimes given monthly to patients for several years. So treatment for this disorder with these injections, it's not a one-time therapy, it's ongoing monthly therapy. And we found that at least for the short-term outcomes, Black individuals did about half as well as white individuals in this study.
And what do you consider short-term?
Short-term is looking at a treatment and then measuring the outcome a month later. So the short-term response was at 1 month and then at 4 months. So we looked after a single injection and after a series of 3 injections. And we found that that Black individuals did less well than white individuals and also less well than Hispanic individuals.
Okay, and so that was the short term. And then what about, I guess in 4 months would be considered longer term, and how did they do?
They did the same. It was fairly similar between both the 1 month outcomes and the 4 month outcomes are both considered short term, because sometimes patients get these medications for a year or 2 years, and they're getting the injections as frequently as every month. And the reason we only looked at short term outcomes is because we were really able to control for all the different variables when we did that. Oftentimes, because there are 3 different medications available to treat this disorder, if someone doesn't respond as well to one medication, then the medication will often get switched after the 2nd or 3rd or 4th injection. So we wanted to reduce the effect of all those variables, like, for example, changing the medications. So that's why we looked at short term, because we knew we had enough data to really draw some meaningful conclusions.
Okay. So as a provider at an urban health system, and given your findings, how do you recommend providers help their Black patients gain access to studies that will better help inform treatment for DME going forward?
Yeah, I think the one of the morals of the story here is that we need more information, right? So, again, my study, while it was very interesting, is the first of its kind to show this kind of treatment. And I'll be honest with you, some of the response that I've had from retina specialists around the country is to sort of look at this study with doubt. And I think the reason they do that is because they don't necessarily have personal experience with seeing less of a response with their own patients. That being said, when you don't run clinical trials that have enough racial and ethnic minorities in them, then it's almost impossible to really be able to draw meaningful conclusions unless the number of people in those trials reach a certain threshold. And so I would say, as much as possible, if African Americans can be willing to participate in clinical trials, and I really think clinical trial coordinators and sponsors really need to make the recruitment of minorities a priority in these trials. Just to give you a sense, the incidence of diabetic macular edema, the disease itself, is actually twice as high in African Americans than it is in white individuals. So that means and the incidence is actually 38%. So 38% of all patients with diabetic macular edema are Black, whereas the general population of African Americans is 13 or 14%. So that's why it's so important to not only recruit ethnic minorities based on the population, but in some cases, if the incidence of the disease is more common in minorities, you really need to recruit more than what you would see in the general population. And that admittedly is a challenge. Can be a challenge, yeah.
Okay, well, so let me ask you this question. I just want to switch gears for a second here. So I was reading that Avastin and the other two drugs, which I'm not even going to try to pronounce because that they were originally designed for macular degeneration, and
Yes.
then sort of repurposed or added on the diabetic macular edema. Are there
Yes.
any drugs that specifically, or are there drugs in the pipeline that specifically treat DME, diabetic macular edema?
That's a good question. So all of these drugs were originally researched and developed by pharmaceutical companies to look primarily at macular degeneration, and both macular degeneration and diabetic macular edema are what we call VEGF mediated diseases. Mm-hmm. So what these drugs do is that they inhibit a growth factor called vascular endothelial growth factor. And so both macular degeneration and diabetic macular edema are mediated by the upregulation of VEGF. And so the rationale behind studying these drugs after they were shown to be effective for macular degeneration was that because diabetic macular edema is also a VEGF mediated process, let's look at these drugs for that disorder as well. And it turns out it actually works. It works like really well for macular degeneration. Like there's a 90% of efficacy. And for diabetic macular edema, it works fairly well. Not quite as well as macular degeneration, but fairly well. But yes, so that's the interesting part about this is that in some ways the results aren't that surprising, right? And the reason why people study macular degeneration so much is because it affects it's the most common cause of blindness in people over the age of 65. Right. And so many people are going blind from it, and as the population ages, you're going to get more macular degeneration. And so from a pharmaceutical company perspective, they have the ability to be able to treat a lot of people with a potential blockbuster, medication. So that's why, the macular degeneration, because so many people have it, that's why there's so much research and development going on for that. But once they were all shown to be effective for macular degeneration, people started looking at it also in diabetic retinopathy. And it's been shown to be quite effective in diabetic retinopathy, but no one's actually looked at whether or not people of different racial backgrounds respond differently to it. And that was one of the reasons why we did.
So, okay, so I understand that they both treat VEGF. They mediate VEGF.
Yep.
But my question really is, are there any plans to create, a drug that specifically treats diabetic macular edema separately
Or diabetic.
from macular degeneration?
I don't know, because I'm not aware of all the drugs that are currently in the pipeline. I know there are a lot of drugs that people are looking at for macular degeneration and diabetic retinopathy. Is there one specific to diabetic retinopathy that's not also being looked at for macular degeneration? I don't know the answer to that question. Sorry.
No, it's okay. It's fair. I was just curious. Yeah. My mother actually had macular degeneration, but that was part of her cancer diagnosis as well. So it's, slightly proposition there. All right. So once Black patients are diagnosed with diabetes, should they be automatically referred to an ophthalmologist to screen for potential eye diseases? Is that something that's automatically
Sure.
done?
The recommendation is that they get screened within the first 5 years of diagnosis. And ideally, they probably should get screened even, I know that was a recommendation some years ago. It may have changed, but they probably should get screened within a year, because a lot of people will have diabetes for a number of years before they become officially diagnosed.
Mm-hmm.
So by the time they actually get diagnosed, they may have actually had the disease for a number of years. So within first 5 years of the disease, I would say, rather than diagnosis, they should see an ophthalmologist.
Does that also go for pre-diabetes, or is that not a concern?
Pre-diabetes, it's quite rare to have eye findings as a result of pre-diabetes. But if you're diagnosed as a pre-diabetic, that means you're getting caught pretty early in the disease process. So I think in those cases, you would be okay to wait, up to 5 years before getting the eye exam. But, it's always good to have an eye exam anyway, just to, make sure your eye overall is generally healthy.
And then, so my final question to you is, how do patients empower themselves, or how do they get educated about gaining more access to these clinical trials? How should that work? How do providers or their patients, how do they go about that?
That's a really good question. So a lot of the clinical trials are conducted. They have a centralized location. So there's often two different types of clinical trials. There are the National Institute of Health based clinical trials, and then you have your industry clinical trials. So a lot of it really is the sponsors, I feel, have to actually go, that being the NIH and the industry, they actually have to make an effort to search out and seek institutions to participate in clinical trials, because the patients can't do it directly with the sponsors. They have to go through, a hospital or an institution that are conducting those clinical trials on behalf of the sponsors, right? So it's really a matter of the study sponsors making it a priority to recruit minorities, and that's what I'm hoping this paper does, is to actually get people to ask more questions and start looking at this with more interest.
That's a good point. Well, I've taken up enough of your time, Dr. Manju Subramanian. Thank you so much for my questions today. I know you're super busy, and I really appreciate it.
Thank you so much, Tamara. It was a pleasure.